I welcome you all to the 10th session of a PRISM Talks series. For those who are new, PRISM stands for Progress in Research, Innovation, Science and Medicine, a webinar series brought to you by Chennai Liver Foundation. Through PRISM Talks, we aim to bring together the clinicians, researchers, public health professionals, and students to share knowledge, experience, and the recent developments in the field. So, as part of this series, today's session is one of the important topic which is important and evolving in both clinical and the public health, which is metabolic dysfunction associated steatotic liver disease, commonly known as MASLD, and its changing definitions, diagnosis, and emerging therapies. So, for this, we are pleased to have Dr. Ganesh as a speaker for today's session, with Dr. Selvam serving as the chair. So, it is my privilege to introduce our chair for today's session, Dr. Selvam. So before let me introduce him. Dr. Selvam is a senior physician and a diabetologist with long-standing contributions to clinical care, academic medicine, and diabetes research. He has served as an assistant professor in diabetology at Kilpauk Medical College and Government Royapeta Hospital, Chennai, contributing significantly to the clinical training and patient care. Currently, he serves as the managing trustee of Aruna Diabetes Research Foundation, Chennai, where he continues to work on advancing diabetes care, research, and community initiatives. He has held several key leadership roles, including positions with the Research Society for the Study of Diabetes in India and the Diabetes Association of India, and has been actively involved in major public health initiatives, including projects supported by the World Diabetes Foundation. He has also been closely associated with Public Health Foundation of India for certificate course in evidence-based diabetes management, and since its inception and contributing to capacity building across the country. We are honored to have him here as of today's session. We welcome you, sir, for our PRISM Talk session 10, sir. So, before I invite sir to take over, a few quick notes for all the participants. All the participants will be on mute, and you may please post your questions in the Q&A box. And as usual, there will be a feedback form which should be shared at the end of the session, and kindly fill it out to receive your certificates. Sir, may I request you to kindly take over the proceedings? Over to you, sir.
Right. Thank you, Dr. Vaishnavi. Thanks and my respect to Professor RPS Shanmugam sir and Dr. Vivek and Dr. Ganesh and all the participants. And thanks for giving me this opportunity. And this is very, very important topic and evolving topic. As RPS Shanmugam sir is here, 30, 40 years before, just we were palpating the abdomen and saying that liver is palpable. That was the message we gained 40, 50 years before about liver. Then after introduction of ultrasound only, more reports are coming as fatty liver, fatty liver. Then after further development only, fatty liver is the cause for insulin resistance. Insulin resistance is the cause for so many metabolic problems like dyslipidemia, diabetes, hypertension, even atherosclerotic vascular disease, all those things. Then recently they have changed the nomenclature from non-alcoholic fatty liver disease to NAFLD to Metabolic Dysfunction-Associated Steatotic liver disease. Why they have changed it means this non-alcoholic, alcoholic stigma and fatty means chubby or fatty liver. So some common man or some patients are worried about this nomenclature. So the scientists involved in fatty liver or non-alcoholic fatty liver disease all over world, from American Association of Study of Liver Disease and European Association of Study of Liver Disease and various other scientific body, they think it over and change the nomenclature in June 23, just hardly 2 years or 2.5 years before, as metabolic dysfunction, because most of the dysfunction are created due to metabolism. So metabolic dysfunction associated steatotic instead of fatty, steatotic liver disease, they have changed. So what sort of problem we are facing because of steatotic liver disease, how to prevent it, how to tackle it, suppose we don't tackle it, what are all the consequences? On those aspects, Dr. Ganesh is going to talk on that. And of course, hepatology now has become a separate specialty in gastroenterology. So they have introduced DM gastroenterology only. Now our MMC also has DM hepatology. So Dr. Ganesh is consultant hepatologist and liver transplant physician at RPS Hospital, Chennai. He completed his super specialty training in hepatology at the prestigious Postgraduate Institute of Medical Education and Research, that is PGI Chandigarh, with over 20 publication or PubMed indexed publication to his credit. He has made significant academic contribution to the field of liver disease. His clinical and research interests included advanced endoscopic technique, metabolic dysfunction-associated steatotic liver disease, viral hepatitis, preventive hepatology, and liver transplantation. So this is all the area he has interested. Of course, we have technology. We can prevent fatty liver or MASLD. We can treat also. Sometimes we revert it also. Today also I have come across one patient. It gets reverted after reducing the weight by adopting the diet advice, etc. Suppose if we don't intervene for 5 to 10 years or 15 years, they may develop a cirrhosis and subsequent complications. Very rarely they develop a hepatocellular carcinoma also. So even he goes to the level of transplanting the liver. And here I want to convey to the other audience, Dr. RPS was the first liver transplant surgeon for our country. Sir, am I correct, sir? 87 or at Stanley only you did, sir? Sir, you had to unmute, sir. Unmute, sir. You have to unmute, sir. Not audible.
Yeah, I did it in 1996 at the government Stanley Hospital.
Stanley Hospital, yes, sir.
First of its kind in the country.
Kind, yes, sir. We all know about it, sir. Very happy and proud to have you here, sir. Thank you so much. And once again, I thank RPS Shanmugam, sir, and Dr. Vivekanandan, and Ganesh. Over to Dr. Ganesh to the topic. Ganesh? Ganesh, you have to unmute. It is mute.
Ganesh, unmute and talk.
Now I'm audible, ma'am?
Yeah, audible.
You are audible.
Yes, sir.
Okay, now I'll share my screen. Hope, thank you for your humble words, sir. Now we'll move on to the topic. Hope my screen is visible, sir?
Yeah, visible.
Okay, sir. Just give me a second for slideshow to begin. Let's move on to the topic of today's interest. So today we will be seeing why this name has changed from non-alcoholic fatty liver to metabolic dysfunction-associated steatotic liver disease, that is MASLD. Our chairperson has made my job easy by explaining what was the initial brief steps about what was taken in that. So apart from this name change, we will be seeing what is the implication in the level of community level, at the level of practicing physicians and patient level. What is the benefit of renaming this disease from NAFLD to MASLD? And also we will be discussing briefly about the emerging pharmacotherapies and FDA approved drugs which is available. And we also will be touching about how to approach this entity and how to help the community to screen this disease and how to proceed with this. So in this agenda of this talk, we will be seeing how they revised it. The previously, which is known as fatty liver disease, now it is known as steatotic liver disease. So how they revised it, and what is the multifold implication of this nomenclature chain at the level of community, at the level of treating physician, and at the level of the patients. So, and what are the therapeutic targets right now we have in MASLD, and what will be the future direction of this disease? So why are we so much worried about this disease, MASLD, or non-alcoholic fatty liver disease? Because the prevalence of this disease in India is very high. It is roughly 38 to 50% in the various studies quoted from the northern part and southern part of the country. That is, every third person has a fatty liver disease. So why are we so worried about if the patient is having a fat in his liver? Because as I said, the prevalence is roughly around 30%. But out of this 30%, 20%, roughly in a period of 5 years, 20% of the patients can develop hepatocyte ballooning and lobular inflammation. That means along with the fat, they might develop inflammation in the liver cells, which is known as MASH, that is steatohepatitis. Along with this fat, they may develop ballooning and inflammation in the liver cells. So from this group of patients, around 20% within a period of 5 years can progress to cirrhosis. What is cirrhosis in simple term? If you ask me, it is the shrinkage of the liver, or the liver is getting shrunken through this process. When the patient is cirrhotic, as we all know, the patient decompensates and develops symptoms and complication of the cirrhosis, such as development of ascites, jaundice, portal hypertension, etc. and etc. So roughly in the given group of cirrhotic patients, progression to hepatocellular carcinoma is 3 to 7% per year. So this disease is need to be concerned, and it is become the most common cause of liver transplant in United States at given point of time. So we can also, you should also be knowing that a patient with steatohepatitis, that is along with the fat with inflammation, can develop hepatocellular carcinoma directly without even developing cirrhosis. So we are so concerned about this disease at this given point of time. So this is the study from All India Institute of Medical Sciences and PGH Chandigarh. They showed that the prevalence of this disease, that is MASLD, varies from 8.7% in eastern part of the countries to maximum 53%. That is, every second person is having fatty liver disease in northern part of the country. And if you see the prevalence in the South India, it varies from 32 to 50%. So let's come to the discussion why they named this disease from NAFLD to MASLD. As Sark correctly pointed out, this change was brought in 2023. They conducted a consensus in Delphi. Delphi is a place in the Greece, European country, Delphi, where experts from the different liver association, from American Association, from European Association, from Indian Association, they gathered in the place called Delphi in Greece. And they come up with the idea of renaming the disease for various reasons. So they renamed the disease from NAFLD to MASLD after the consensus. Mainly, as I said before, it is regarding the stigmatizing term which is there. That is non-alcohol, alcohol in the disease which is not having alcohol usage, and also a fatty is considered as stigma for them. We will be seeing detailedly about how they came through this idea. Before that, we will be seeing how to define this new term MASLD. So MASLD means metabolic dysfunction-associated steatotic liver disease. So to enable a patient to have MASLD, one should have fat in the liver. The fat in the liver can be diagnosed either by ultrasound, biopsy, or shear wave elastography. The percentage fat should be more than 5%, and at least they should be identified with help of shear wave elastography or ultrasound or biopsy. Along with the fat in the liver, one must have one out of these given 5 metabolic risk factors, which includes diabetes as defined by AGA, and hypertension, obesity, and the cutoff of obesity being 23 for Indian population, and triglycerides of more than 150 milligram per deciliter, or HDL of less than 40 and less than 50. That is less than 40 for males and less than 50 for females. I revise it once again. So define a patient with a MASLD, one should have fat in the liver. Along with the fat in the liver, he must have one among the 5 metabolic dysfunction: either diabetes, either hypertension, either obesity, either hypertriglyceridemia, or low HDL. Okay, hope I'm clear in this one. So once again, I'm revising to make sure everybody is clear in this one. A patient should have fat, plus he should have one among the 5 metabolic dysfunction. So I hope I'm clear in this one. So another new term was introduced in this Delphi consensus, that is in 2023. They introduced a new term called as MetALD. What is MetALD? Previously, in the definition of MAFLD and NAFLD, whenever a person consumes alcohol, they can't enter into this entity of NAFLD or MAFLD. So they came up with a new idea called as MetALD. What is MetALD? Along with the definition of MASLD, a patient is having fat in the liver and he is having one among the 5 metabolic risk factor. Along with this, if a patient consumes alcohol between the ranges of 20 to 50 grams for female per day and 30 to 60 grams of alcohol per day for male, they fit into definition of MetALD. That means if the patient is consuming alcohol at the rate of 20 to 50 grams per day for females and 30 to 60 grams per day for males, plus he should also satisfy a fat in the liver plus one among the metabolic dysfunction, then the patient comes into the definition of MetALD. So this is a new term which was introduced. Previously, they used to use a term BASH, but it was not consensus. This term is well consensus. That is MetALD. MetALD is the patient with MASLD along with alcohol intake between 20 to 50 gram for female and 30 to 60 gram for male. Any alcohol intake above this is not considered as MetALD. They directly go into the definition of alcohol-associated liver disease. That means a patient who is consuming alcohol in significant dose, more than 60 gram per day or more than 50 gram per day, directly goes into the entity of alcohol-associated liver disease. So apart from this, some patient is having fat in the liver, but he is not alcoholic, he is not having any metabolic dysfunction. So what to label them? What to label their diseases? So the patient is not consuming any alcohol and the patient is not having any metabolic dysfunction, means he is not diabetic, he is not hypertensive, he is not obese, and his triglyceridemia level is also well controlled, but still he is having fat in the liver. So those people can be classified in these three categories. For example, a patient who is having CAM or some drug-induced liver injury can come in this entity of specific etiology, steatotic liver disease, or some monogenic disease such as hepatitis B, hepatitis C, Wilson's disease, celiac disease, malnutrition. They all come under this specific etiology. The patient should not have taken alcohol, and the patient should not have any metabolic dysfunction. They come in this category. So if when we are negative with all the things which we have, still we have a fat in the liver, then they get characterized into cryptogenic SLD. So I want people to understand what is MASLD, how they have defined it. That is fat plus one among the 5 metabolic dysfunction. So what is the goal of renaming this disease? This, if you see in the previous naming, that is NAFLD, non-alcoholic fatty liver disease, there is nothing to describe the pathobiology of the disease in the name. But in this name, MASLD, Metabolic Dysfunction-Associated Steatotic Liver Disease, the name itself defines the pathobiology of the disease. And it also helps in improving the diagnostic accuracy. And as Sar said, it will remove that stigmatizing term that is either the fat is also removed, the alcohol in the patients who are not consuming alcohol is also removed, and this also encourages patient-centered approach. So what happens to the patients who are already classified as NAFLD? Will their definitions, will their studies, everything go away? No. So they did an analysis. This was conducted in our institute, PGH Chandigarh. They studied of more than 7,700 Indian patients, and they found that there was nearly 98% overlap between the patients who are NAFLD and MASLD, and they had a comparable disease severity and non-invasive test performance. For example, NITs, which we called as non-invasive test without biopsy to diagnose MASLD, was having very good correlation with the patients who are previously labeled NAFLD and right now diagnosed MASLD people. So there is no afraid about the previous studies which was conducted on NAFLD. Will it apply for MASLD? Yes, it will apply. So what was the implication of this for practicing clinical physicians? So impact of this name change, the MASLD can be diagnosed with coexistent liver disease now. As I said, previously, if a patient is consuming alcohol, whatever rate he is, he will not come into the definition of the NAFLD. Now, with this new entity called as MetALD, they can be diagnosed along with the coexisting liver disease also. And this clearly describes the disease and also helps us to understand how each disease helps in progress, how each disease coexists and how the disease progresses with presence of metabolic dysfunction. This also helps us to manage different causes of liver disease simultaneously. As this term has come now, the new terminology gets greater adoption, and next step is to implement this change in ICD. So what is the public health implication? The main public health implication is to drop the stigmatizing term from the name fatty and alcohol. As I said, fatty is considered as stigmatizing by most of the associations, either from Asian, American and European association, and the presence of alcoholic in non-alcoholic fatty liver is also considered as stigmatizing term. So this two major change was in the latest name. The terminology, as I said, the pathobiology is very well explained in the new terminology. So this was the important public health implication for the change of name. So what is the implication of MetALD? So as I said, MetALD is a patient who is consuming alcohol between 30 to 60 grams per day, plus the patient is having metabolic dysfunction along with fat in the liver. So the emergence of MetALD will drive us to understand the impact of metabolic syndrome on ongoing alcohol use in the patient. For example, a patient is having alcohol use disorder and how this metabolic syndrome will impact his disease progression, etc. Whether the therapy for reversing MASH-related fibrosis are effective in MetALD patient with stage 2 of fibrosis. For example, there are so many therapies which is available for MASLD right now. So what will be the use of these drugs in the patients with MetALD? We will get it. And there is also the need for, with the introduction of this new term, there is also the need for introduction of the biomarkers to differentiate between these two entities. So what are the broad classification of potential therapies which we have in MASLD? So as we all know, all of our physicians are using saroglitazole for left and right for MASLD, which is a PPAR agonist. peroxisome proliferator activated receptor agonist, which is alpha and gamma dual agonist. So this has been used by many of our physicians for the treatment of the MASLD. And other group of drugs such as FXR agonist, which is obeticholic acid, and thyroid hormone receptor beta agonist is resmetirom, which is the first FDA approved drug for patient with MASLD and significant fibrosis, and thus drug has shown to reverse the fibrosis. And another drug which was approved recently in August 2025 is semaglutide Ozempic, which is famously used nowadays, which also got its FDA approval recently. It is also shown to reduce the fibrosis in a patient with significant fibrosis and reverse the fibrosis. Now, another upcoming drug is tirzepatide, which is Mounjaro, which is also been famously an FDA approved for patient with obesity. It is FDA approved. For a patient with ongoing fibrosis and significant fibrosis, it is not being approved. So another upcoming drug is efruxifermin, which is FGF growth factor analog, and still the drug is in phase 2 study. And SGLT2 inhibitor, example empagliflozin, dapagliflozin, is also an ongoing study. So we have 2 FDA approved drugs, which is resmetirom and semaglutide, and another ongoing drugs which we use in India are saroglitazole, vitamin E, etc., etc. So we'll be seeing little about all the challenges in the drugs which we are using. So a patient for a drug to get an FDA approval, it is very difficult for a drug to get FDA and EMA. EMA means European Medical Association guidance. So to get an FDA approval for a MASLD drug, how it works? The patient should undergo a paired biopsy, means a patient who is enrolled in a clinical trial should undergo a biopsy before the onset of the procedure and 52 weeks after the onset of the procedure. This will significantly tell how much the fibrosis are reduced. And also there should be improvement in steatohepatitis. That is, as I said in the beginning of the slides, there should be inflammation improvement and also improvement in the fibrosis. So these two should occur. Then only they will give an FDA approval, and the patient should undergo biopsy for 2 times, that is before the onset of the procedure, after the onset of the this one. So the need for the liver biopsy is very important. And placebo, for example, what are the challenges that I said? Need for the liver biopsy is very difficult, and the patients are not willing to give a biopsy 2 times, and also placebo response in MASH trials is also very high. So, and these trials we are not clear cut. We don't have a clear cut time how far the trial should be conducted. So these are the challenges. Main challenges is the paired liver biopsy. So we will start with the drugs which we know initially and we are using it right now. So vitamin E and saroglitazone has been used by many physicians, practicing physicians, for the treatment of the MASLD. So we will see and brush about the data which we have regarding vitamin E and saroglitazone. The usual dose of vitamin E which you use is 8,800 international units per day. So this age-old study, but it is a robust study which was given by Arun Sanyal and group, which was published in New England Journal of Medicine. They did a biopsy proven study. That is, it is an histology study between pioglitazone, vitamin E and placebo. The vitamin E was proven to be superior to pioglitazone and placebo in improvement of the steatohepatitis, but there is no improvement of fibrosis. So mark my words, there was no improvement in fibrosis, there was only improvement in the steatohepatitis. That means there was improvement in the inflammation of the liver cells, but there is no improvement in the fibrosis. The fibrosis has not been reversed by this drug. So another famous drug, saroglitazone, which is PPAR agonist, alpha and gamma agonist, which has been used for the treatment of NAFLD. We have only one histology proven study for this drug, and other non-histological studies which are close to histology can be said. This drug also reduced the ALT levels as shown in the studies. Saroglitazone reduces ALT levels. It reduces the fat content. It improves the insulin resistance. It can be used to treat diabetic dyslipidemia. But this drug failed to show improvement in the fibrosis. Still, this drug has been approved by Drug Control General of India. So this drug has reduced the steatohepatitis significantly, but there is no improvement with the fibrosis according to the available studies right now. Even in the histology study, this saroglitazone drug has not shown to improve the fibrosis, but it has definitely shown to improve the steatohepatitis and liver enzymes. So 3 drugs currently which is approved by the Indian Drug Control General of India is vitamin E, saroglitazone and pioglitazone. These are the only 3 drugs which are approved by Indian Drug Control Program: vitamin E, saroglitazone, and pioglitazone. As we all know, pioglitazone is not being widely used because of its black box warning of prostate cancer, and it can't be used in patients with without diabetes also. So the superstar of the MASLD drug, which is known as resmetirom, this is the first drug to get the FDA approval in the year 2024. This drug regulates the metabolic dysfunction in the liver, including carbohydrate metabolism, cholesterol homeostasis, triglyceride handling. So as we know, this thyroid hormone receptor beta is majorly expressed in the liver cells, and they produces a beneficial effect by reducing the hepatic steatosis and preventing the liver injury by mechanisms such as mitophagy and increased capacity to handle the oxidized free fatty acid. This elevated TSH level is associated with increased risk of advanced fibrosis in MASLD, even in euthyroid status. So, how this drug trial was framed? This is a phase 3 trial. This is the trial which helped resmetirom to get approval for fast track approval for treatment of MASLD with significant fibrosis. So in this study, as we see, nearly 960 patients were included, and around 640 to 50 patients was in resmetirom group and 320 patients was in placebo group. The trial went for 54 weeks, and the patients underwent a paired biopsy, as I said. So the drug showed improvement both in steatohepatitis. There was significant improvement in steatohepatitis and also significant reduction in fibrosis by more than one stage. As I said previously, vitamin E, saroglitazone, pioglitazone, they have shown improvement in the steatohepatitis, but there were no improvement with fibrosis. But this is the first drug to show improvement with the fibrosis. Because of this, the drug has been approved by the FDA. But how it is not feasible to use this drug in India? Because of its prohibitive cost. As we know, we are in a developing country like India, then most of the people are not insured for the medical category here. So if you see, the cost of the drug is roughly around 14,500 pill per day, and it translates to roughly 4,36,000 per month, 4,36,000 per month for the treatment of this disease. This kind of prohibitive cost is not feasible in Indian population. But so there was one easy availability of this drug, which was made through the NGO organization through the era of Bhutan, where the 100 mg of drug is now available at subsidized cost of 10K per month. So this comes to the one of the NGO organization, and they travel through the Bhutan, and we need to give our prescriptions, and they should be authenticated with the Aadhaar identification of the patient, and the drug is being straightly delivered to the patient who are at the need of this drug. Still, it is an evaluating state. We are using this in central metropolitan cities of the India, and it needs some time for it to get an easy availability all over the country. So as I said, in India, we will not be able to get this drug. We will not be able to ask our patients to undergo biopsy to treat this disease, but we can start the patients on the basis of the liver stiffness measurement. What is liver stiffness measurement? Which is called as VCTE, which is a help of fibroscan machine. We can measure this LSM. So if the LSM is between 10 to 15 kilopascals, it is an excellent candidate for the treatment treatment with the rematch. And if it is between 15 to 19, still, that is, if the patient is having a LSM between 10 to 19 or 20, the patients are excellent candidate for treatment with resmetirom. And other categories, other non-invasive biomarkers such as magnetic resonance, elastography, ELF score was given, but we will this is not easily available in given Indian setting. So we'll go with an LSM, which is easily available in all of the tertiary care centers in given point of time in our state, in India, etc. So LSM value, please note that LSM value between 10 to 20 are excellent candidates to get treated with resmetirom with a patient with MASLD. Yes, of course, we should rule out other causes of the steatosis and fibrosis, example, alcohol use disorder, and viral hepatitis B, C, and if the patient is having suspicion of autoimmune hepatitis, those things should be ruled out with the non-invasive biomarkers itself. And the patient, if the patient is having an LSM between 10 to 20, the patients can be clearly started on resmetirom. So what is the another drug? Semaglutide, which was an GLP-1 receptor agonist. This is a famous drug used for obesity at given point of time, and it also been approved for patient with MASLD and significant fibrosis for reversal of fibrosis. So commonly we used to treat this drug to treat diabetes mellitus and obesity. The receptors are present in pancreas, distal ileum, colon, and central and peripheral system, and there is no receptors in the liver. So it increases the insulin secretion, it inhibits the glucagon secretion, and it delays the gastric emptying. And in central nervous system, it reduces the expression of serotonin and leads to decrease in appetite. By doing all this, semaglutide helps in reducing the weight and thereby reducing the fibrosis also. The initial study of semaglutide, which was done in the year 2021, which was a daily dose study. It is a phase 2 study, but daily the patient was given 0.4 milligrams subcutaneously. But this is a non-biopsy study. Non-biopsy means the patient was not subjected to biopsy before and after the trial. Still, this drug showed reduction in the liver fat, but there is no reduction in the liver stiffness. This is the initial study which was done in 2021. But this landmark trial, which is Essence trial, which is a 5 years long trial, which is still ongoing, but which is for the patient with MASH patient. That is, this is a biopsy study. Means before the onset of the trial, the patient will be subjected to the biopsy. The patient should have steatohepatitis and significant fibrosis, and those patients were allocated 2:1 to receive semaglutide and placebo. Roughly 800 patients were included in the study, and we have got the interim results at the end of 72 weeks. This trial is planned for 5 years, but we have got the result of 1.5 years. That is 72 week study. At the end of 72 weeks, what is the changes in the patients? We have got the results. Based on this phase 3 study, the drug has been approved for the treatment of MASLD. So this is the second FDA approved drug. There are only 2 FDA approved drugs at present in the market for treatment of MASLD. One is resmetirom, second is semaglutide. So here in this study, 800 patients were included from multi-centers. It is a multi-center study. Even in India, 2 or 3 centers from India were also participating in the study. So, and this semaglutide was given at the rate of 2.4 milligrams subcutaneously per week, and placebo patients were 266 patients. So this drug showed significant improvement in steatohepatitis and significant improvement in fibrosis. Also, the patient had a weight loss of 10 to 11% in this group. Based on the study which was published in NEGM, this drug was approved. This is the second drug which is approved for MASLD with significant fibrosis by FDA. So another upcoming drug is called FGF analog. We will not be seeing detail about those drugs because these are not FDA approved right now, and these are all in phase 2 studies. But we will be touching and briefly knowing about these drugs. Okay, so what is this drug? This is an hepatokine, and it enhances insulin sensitivity and increases the glucose uptake in adipose tissue and skeletal muscles, and it increases the beta oxidation of the mitochondrial beta oxidation of the free fatty acids. So this efruxifermin has currently cleared the phase 2 trial. This has been FGF hormone FGF21 agonist. This is FGF21 agonist. In this phase 2b trial, it has shown to improve the steatohepatitis and also improve the fibrosis, and both is seen at the end of 24 weeks with a dosage of 28 milligram per day. But still, this has been not approved by FDA because it has cleared only the phase 2 trial. Phase 3 trial for this drug has been started. Once it clears the phase 3 trial, this drug also will be approved for the treatment of MASLD. So another famous drug, which is tirzepatide, which is also famously known as Mounjaro, which is an FDA approved drug for obesity, but still this is not approved for the treatment of MASLD, obesity and fibrosis. It has anyhow cleared this phase 2 study. Both the drugs, Mounjaro and this efruxifermin, they have cleared the phase 2 study and they have entered the phase 3 studies. Once they clear the phase 3 study, they might also be approved for FDA. Other incretin based agonist are pemvidutide and cotadutide, which are all GLP-1 and glucagon receptor agonists. They are also under their phase 2b study. Here I need everyone to understand about this Mounjaro drug, which has been approved by FDA for the treatment of the obesity, but still it has been not approved for the treatment of MASLD with significant fibrosis. So another fascinating drug is denifanstat, which inhibits the FSAN. FSAN is fatty acid synthesis inhibitor, which inhibits a pathway de novo fatty acid synthesis. So by inhibiting it has shown to reduce the fibrosis and also fatty steatosis in the liver. But still, this is also in the phase 2 study. but this is improving. This is a fascinating drug which might come in the future also. So until right, and there are some genetic modulation which is being tried right now. This is very advanced trials, but still everyone should know that these two genes, HSD17B and PNPLA3, these are the two main important genetic polymorphism which is noted in patient with MASLD and progression to fibrosis. So now the pharma companies are targeting this gene and making a genetic based therapies for treatment of MASLD, but all these are in a trial basis. Still it is not into a bigger range trial. So what are the additional simple agents which we have apart from our resmetirom and semaglutide? So SGLT2 inhibitors has been used for various conditions such as CKDs and CADs and for cardiac condition, etc. But there are no promising trials in the field of MASLD. Still, people use this drug. One trial has been currently registered regarding dapagliflozin in comparison with pioglitazone. It is a biopsy-proven study. If this study comes out, we will have a good data for the usage of SGLT2 inhibitors in patients with MASLD. So another famous drug, which is ursodeoxycholic acid, which has been used left, right, and center by various physicians and for the treatment of the MASLD. As soon as one sees the report with fatty liver disease, every patient, nearly 70 to 60 patients, 70 to 60% of the patients have been put on this drug. Are we right in doing this? It reduces the alanine transaminases level, but there is no data regarding this drug in reduction of steatosis and fibrosis. Absolutely, this drug used to will reduces the ALT, but we are not sure how far this will reduce the steatosis and fibrosis. We don't have data regarding this, the usage of this drug. And another drug which is commonly adimetionine, which is known as Heptral, Hepriel, etc., 400 milligram drug. There is a sparse data regarding the reduction in SGPT, and it is also a very good role in the usage in alcoholic associated liver disease. But these two drugs, ursodeoxycholic acid and methionine, we don't have a proper data regarding the reduction of steatosis, fibrosis. We don't have any histological data. Histology is very important to document a study in the field of MASLD. So, and this drug has been now recently introduced, and it has been publicized as very high these days. And this is also considered to receive the CDSCO approval for treatment in MASLD, which is NOR-UDCA. This is nothing but that it is an UDCA with the elimination of the methylene group. So it is resistant for amidation with taurine and glycine compared to the UDCA. So what is the mechanism of action of this NOR-UDCA? This drug has been recently publicized very famously and it has been told to give an approval from the CDSO, that is Central Drug Control of India, for treatment of the MASLD along with your saraglitazole and vitamin E. So we will see a little bit deep about this drug. It causes positive effect on FXR agonist and reduces transforming growth factor beta and reduces collagen type 1. By doing this, it regulates the cholesterol levels and increases the insulin sensitivity and inhibits pro-inflammatory cytokine production. By this, it reduces the fat content, inflammation, and fibrosis in the liver. This is postulated. So, what are the previous trials which we have regarding NOR-UDCA for treatment of NAFLD and AALD? So there is a trial which was done in the year 2019 initially. They showed significant reduction in ALT at the end of 3 months. As I said previously also, this drug have shown to reduce the ALT, but there is no strong data to suggest reduction of fibrosis or steatohepatitis, and we don't have any biopsy proven study for this drug. So based on this phase 3 clinical study which was conducted in India, based on this study, NOR-UDCA has been currently approved in the India. Let's go and dissect this study and understand what they have done in this study to get this approval. So the primary objective of this study, of this NOR-UDCA study, is to evaluate the efficacy of NOR-UDCA versus placebo for the treatment of NAFLD or MASLD, and also to evaluate the safety of this drug in patients with NAFLD and MASLD. So they included the patient who have with the fibroscan values of F2 and F3, that is between 8.2 to 13 they have included in the study, and whose aminotransferase ALT level is more than 1.5 times and less than 4 times they were included, and who are able to maintain a stable diet including non-alcohol intake throughout the study was included in this study. This drug, which is at the rate of 1500 milligram per day versus placebo, showed significant improvement and normalization of ALT at the end of 12 weeks. Please concentrate in this. There was improvement in ALT with the non-invasive biomarkers only, that is blood test based. And there was improvement in the fatty liver stage by fibroscan, not by your biopsy, etc. So there was reduction in the fat as documented by fibroscan, and there was improvement in this NFS score. NFS score is nothing but it is a blood biomarker to detect the fibrosis in the liver. So it includes diabetes, age, ALT levels, and the age of the patient. So based on this parameters, NFS score is a score which is based on the blood biomarkers, and that also shown to be improved with the help of this drug at the end of 24 weeks. But this is not an biopsy proven study. Based on this unpublished, and one more thing, this study is not yet published in any of the journals. This based on this unpublished study and unpublished phase 3 study, the CDSCO, Central Drug Standard Control Organization of India, gave approval to use this drug for the treatment of MASLD. So what is take home point from this study? If you ask me, this is a non-histology study and it is a non-published data. And there was improvement in NFS score and ALT reduction, I agree, but still it is too early to decide and use this drug for the treatment of MASLD. MASLD. So even though I'm showing this slide in last of just in the last of my presentation, this is the very important slide. Everyone should note on it. So lifestyle intervention is the cornerstone for the treatment of MASLD. Lifestyle intervention is the main key success for the treatment of MASLD with significant fibrosis. As shown in the study, which was published in 2015, a weight loss of more than 10% in a patient with MASLD and significant fibrosis has shown to reduce the steatosis and complete restoration of the steatohepatitis in 90% of the population, and regression of fibrosis in 45% of the participated population. That means if a patient is losing a more than 10% of his body weight by the lifestyle, that is regular exercise, hypocaloric diet, and etc., there is a very good chance of 90% for resolution of his steatohepatitis and 45% and regression of the fibrosis. So let's revise about the available drug in PRISM. So we have only 2 FDA approved drugs at present for treatment of MASLD with significant fibrosis. That is resmetirom and semaglutide. And the drug which is approved in India by the different bodies includes saroglitazone, vitamin E, pioglitazone, and nor-UDCA. But regarding this nor-UDCA, I will not hold for this because it is a non-published data and it is a non-biopsy data. So still we will use saroglitazone and vitamin E. Upcoming promising drug, as I told, is FGF21 analog, which is efruxifermin. So now we will see how to approach these patients, with fatty liver. So whenever a patient is coming to your clinic with the fatty liver in using ultrasound, he is coming to your clinic, patient is coming to our clinic with a report of fatty liver. How to approach? First, you should ask any other history which is contributing to the fatty liver. For example, is alcohol intake. Any history of hepatitis B and C in the family, and we should make sure that hepatitis B and C is negative. And after this, after roughly ruling out, and we should be aware that the enzyme should not be in thousands, it should be in hundreds. This is a basic clinical approach. It should be in 60 to 70, 60 to 80s, in that range, and it should not be in 300, 400. If it is in 300, 400, other contributing factors such as drugs, autoimmune hepatitis should be ruled out. So now a patient has come to you with a fatty liver disease, in his ultrasound, and he has come to you. Now we should ask for other histories such as alcohol use, hepatitis B. We have ruled out everything. Then what we should do? We should ask the patient to get a CBC, complete blood count, which has platelet in it, and we should calculate these 2 scores at the community level. A patient is having ultrasound report showing fatty liver disease, and the patient has been other causes has been ruled out, and patient should also have any of the one metabolic risk factor. As I said, the patient should be either obese, diabetes, or a patient is having dyslipidemia, etc. Then you should calculate these 2 score, which is very easily available by doing a complete blood count, which is FIB-4 score and APRI score. So FIB-4 score has a age as an entity such as age, AST level, ALT level, which is available from our liver enzymes test, and the platelet count, which we can get through the CBC. And APRI score includes AST and platelet alone. So a patient with a fatty liver disease in his ultrasound, we get him a CBC, we get him a liver function test, and we rule out other causes such as hepatitis B, hepatitis C, and if he is having any metabolic dysfunction, then we see if the score as shown, if it is FIB-4 score is more than 1 and APRI score is more than 0.45, then he should be referred for a fibroscan. Surely he should be referred for a center which has a fibroscan for further evaluation. If his score is less than 1 and less than 0.45, he can be managed and followed with the lifestyle interventions alone. I will be describing about the lifestyle interventions which should be done for this patient. So the patient who are at risk are the patient with FIB-4 score of more than 1 and APRI score of more than 0.45. By using this simple algorithm, which is given by our own INASL, which is Indian Nation Association of Study of Liver Task Force in 2023. So whenever a patient is having fat in his liver, and if the patient other conditions have been fairly ruled out, with the help of simple complete blood count and LFT, we can categorize him whether he is at the risk of developing fibrosis or not. If his score is more than 1 and FIB-4 score is more than 1 and APRI score is more than 0.45, no need to memorize these formulas also. It is easily available in medical calculators nowadays to calculate this score. And if it is there, the patient should be referred for the centers with transient elastography. Refer to the center which have liver stiffness measurement. So if the score in the LSM score is between it comes with the two reports. One is CAP, which includes the steatosis, and other is LSM. If the LSM score is 8.2 to 13.6, those candidates merits treatment with pharmacotherapies. Apart from that, if the score is less than 8, if the score is more than 13.6, giving pharmacotherapy is not going to be helpful for these patients. Hope I'm clear. The LSM value of 8.2 to 13.6 is considered as a patient group who can be treated and improved with the pharmacotherapies which we have seen, mainly resmetirom, semaglutide, saroglitazole, etc., etc., etc. So we should give only the patients who are having LSM of 8.2 to 13.6 with any of the pharmacotherapies. Apart from that, all other patients should be put on lifestyle intervention. What are the three major lifestyle intervention we should advise for a patient with MASLD? Includes 30% hypocaloric diet, 10,000 steps or at least a half an hour of physical activity per day, etc. So lifestyle intervention and making them to achieve a weight loss of 10% at the end of 3 to 6 months will help them to resolve their steatosis and fibrosis. Apart from this lifestyle, if the patient LSM is between 8.2 to 13.6, that are the patients who will be benefiting with the pharmacotherapy. Any patients with more than 13.6 have not shown to benefit with the help of pharmacotherapy. Still, this was given by our Indian population. Still, some studies told that we can extend this to 10 to 20. So take home message is that 10 to 20 kilopascal, that is LSM value between 10 to 20. And if you are ruling out all other causes such as alcohol association and the patients with hepatitis B and C, and we are also ruling out other autoimmune rare conditions such as autoimmune affiliated if indicated, then if you put this patient in a risk categorization and if FIB-4 score and APRI score is more than 0.45, and we refer them for a transient elastography, and if the elastography report comes between 8.2 to 13.6, they are the excellent candidates to receive pharmacotherapy along with lifestyle intervention. Also, I suggest the patients between 13 to 20 also can receive the pharmacotherapy as I showed in the treatment with resmetirom group. They also used to get benefited, but these are the group of the patient who are about to get excellent benefit from the usage of the pharmacotherapy for MASLD. So what are the key summaries from this algorithm is that lifestyle intervention remains the cornerstone and the first step for the treatment of the MASLD. We should need to evaluate the etiology of steatosis. As I told, we should be able to at least remove other causes such as alcohol use disorder, hepatitis B and C, and autoimmune hepatitis if suspected. And the pharmacotherapy and referral to gastroenterologist, hepatologist to be done when the patient basic screening scores, that is APRI score and FIB-4 score is elevated, and if the LSM is between 8.2 to 13.6, those are the patient with the excellent improvement and reversal of fibrosis with these available drugs, which is vitamin E, saroglitazole, and semaglutide and resmetirom. Yes, any patient with significant fibrosis, that is LSM of 8.2, 13.6 and above, should go on HCC surveillance because these patients can land up in cirrhosis and hepatocellular carcinoma later. So what are the future prospects of the upcoming pharmacotherapies? So we'll be getting more AI-based models and AI-based algorithms to manage these patients. And another upcoming drugs such as dual and triple agonist, GLP agonist, same like GLP agonist, FGF analogs, SHO, genetic therapy, as you see, personalized treatment may also come up. So we also should have an important thing called metabolic clinic, integrated metabolic clinic, where various physicians such as endocrinologists, hepatologists, gastroenterologists, physicians, and bariatric surgeons should able to sit together and approach the patient holistically. Apart from this pharmacotherapies, we also have endoscopic and laparoscopic bariatric approach to reduce the obesity, by which we can improve the fibrosis in the liver. Also, we will not be going into those things because it is out of the scope of this topic. And so main take home point is that how is the name evolved? Why is the name evolved at the level of community, at the level of physicians, at the level of the patients? So mainly to remove the stigmatizing term and also to bring in the pathobiology of the disease into the name. So even though this is a complex disease with multi-axial disease pathology, with a holistic approach, we can have a hold over this disease. And approved treatment of very sparse, as for now, we have only 2 FDA approved drugs, which is resmetirom and which is semaglutide. Apart from that, we have 2 or 3 drugs which are approved by Indian government for use, but those drugs are not shown to improve the fibrosis. And upcoming, so many potential drug formulations are coming, and we need to, within a period of decade, we will get at least 5 to 6 FDA approved drug in this market. So all fatty liver needs evaluation, as I said, but not all fatty liver needs pharmacotherapy. We should be clear about that. All fatty liver needs evaluation, but not all fatty liver needs pharmacotherapy. The pharmacotherapy will be beneficial only if a patient is having a significant fibrosis, that is LSM between 8 to 13.6, as I said. So thank you. Hope I completed. Am I audible, ma'am?
You're audible. Right, doctor. Thank you, Ganesh.
Thank you, sir. Thank you so much, sir.
Yes.
Thank you, Ganesh. You have
Thank you,
covered
sir.
very well from the the disease to approved and the DCCI approved drugs also you have evaluated, and you have told about the importance of lifestyle modification, LSM. As you said, without lifestyle modification, without diet and exercise, whatever drug we give also, whether it is fatty liver or your diabetes or hypertension or dyslipidemia, nothing is going to be helpful. So better our people should adopt the lifestyle modification. But unfortunately, the current population is not understanding, realizing,
yes, sir.
And they eat all fatty diet and energy-dense diet. Many of them are obese before marriage itself or during adolescence itself. And many develop fatty liver, diabetes, hypertension, even or stroke, infarction within the age of 45. Within the age of 45, the productive life is getting spoiled by the modern lifestyle, dietary habit, and always sitting in front of TV, computer, cell phone, etc. These two are spoiling. On top of it, smoking and alcohol. You have very well highlighted about the modification. So drugs alone will not help. Drug therapy alone will not help.
Yes, sir.
So
Yes.
now we will discuss about. So there is one question. What about PCOS?
Yes,
of
sir.
course, PCO. Please, your kind reminder. One question was there. 1 minute. I learned that women with PCO also will develop fatty liver. Do we have any evidence?
Yes, sir. There are so many evidence to tell the patient with PCOD. So we should understand. Hello, sir. Shall I?
Your answer.
Am I audible, sir?
PCO.
So I'm not audible, sir. Yes, sir. Regarding this PCOS and association with MASLD, the patient who are having PCOS, and roughly the data suggests that roughly 70 to 80% of the patient with underlying PCOD will land up in metabolic dysfunction-associated steatotic liver disease. And this data also applies for patient with diabetes mellitus. What happens here is this: the major culprit here is the insulin resistance. So here also the main association between the PCOS and MASLD, if you link both the things, the insulin resistance is the main culprit in this pathology of this causative pathology of this PCOS and the MASLD. So yes, the PCOS patient should screen them very frequently to identify the chances of developing MASLD, at least I recommend them to get screened once in 6 months. And if they are at the risk of developing significant fibrosis, they should be definitely referred to a gastroenterologist or hepatologist for the treatment of the significant fibrosis. If they are not at the risk, they should be definitely put on lifestyle intervention along with their routine medications for PCOS.
You can stop the screen sharing.
Oh, sorry, sir.
Yes, Ganesh.
Yes,
Ganesh, insulin resistance is due to availability of insulin is there, the tissue is not accepting, isn't it?
Yes, sir. Yes, sir.
That is the main thing. Is it the fat that is blocking the insulin availability, or any other chemical or cellular changes that is avoiding the insulin or preventing the insulin to act on that, not on the fats?
Until now, this is the hypothesis, sir. Until now, the hypothesis is that it's all because of the reduced fatty oxidation. As you said, it is all because of the fat. But there are more pathobiologies which are coming upon, like regarding the genetic variation which the patients are having. For example, as I showed in my slide, the PNP-LA3 and this HSD17B, those things are also coming up in very higher rate. Until now, even though there is so much advancement in the drugs, etc. and etc., still the pathobiology of the MASLD is not completely understood by anyone. They, as we also see in all the trials, as they say, still we need to correlate. Some few points I want to tell is that main thing is that fatty acid oxidation. As I showed, there is another one drug which is inhibiting this de novo fatty acid synthesis, and by preventing this, we are able to control the fibrosis and steatohepatitis. So it all comes under the broad circle of fatty acid synthesis right now for the pathobiology of the MASLD per se. So pathology of MASLD is another huge topic. In view of constraint of time, I was not able to discuss that at this given point.
Yeah, that's right. I agree. And there is another pathology coming up now, is a fatty pancreas.
Yes, sir.
Fat deposition in the pancreas equally.
Yes, sir.
I used to tell, if there is even the chronic pancreatitis, we used to call it a cirrhosis of the pancreas. Isn't it?
Yes.
And like that, the fatty pancreas also can lead on to non-availability of insulin. Is it anyway connected with that?
Sir.
Yes, sir.
Yes, sir. Sir, excess fat anywhere in the body is harmful, sir.
Correct. Yeah. What's a problem in the pancreas? Any
Yes, sir.
beta cell destruction is there? Beta cell function is reduced. What is it?
Whether it is visceral fat or perinephric fat or epicardial fat or liver fat, wherever the fat is excess, that is harmful, sir. So as you correctly told, once the fat cells are the fat globules inside the cell not allowing the insulin to get into it and act on that. Insulin is in excess, but it is not getting metabolized.
So to answer this question, recently.
Yes, Ganesh. Ganesh, go ahead. So Ganesh wants to tell.
Sir. Can I intervene, sir?
Yes, go ahead.
Yes, sir. Recently in 2026, they come up with a consensus for this fatty pancreas itself, sir. It is available in online, which is given by the European Society. So they have came with a very beautiful consensus, and they told that the patients who are labeled as idiopathic pancreatitis for a long time, the patients who are not even diagnosed with a genetic and metabolic test, which is not available in developing countries like India. Now they are telling that by proving, and we have very high-fi diagnostic modalities such as magnetic resonance elastography for the pancreas. So we can even image and find out what is the fat content in the pancreas. And based on this obesity, based on the age, they have come up with the scores which will help us to classify and stratify the risk of patients who might develop of acute pancreatitis because of the fatty pancreas itself. We will have, if we have a time, we can cover this also in a later part of the talks in upcoming sessions. So this is very interesting topic and very upcoming topic. The fatty pancreas should be understood by us. Now this is coming up next to the major disease like MASLD, because so many patients, young patients now, because of the dieting habit, because of the cholesterol, bad cholesterol intake, they land up with a severe obesity, the BMI of more than 35, 34. They have come up with a very good consensus recently by the European Association in 2000. It was just published. So they have come up with very good consensus. They have given a risk factor stratification score. They have given a calculator how to classify these patients who are at the risk of developing fatty pancreas, etc.
Thank you.
So this
Thank you.
is
Thank you.
itself in a new entity.
Any other question? I think they are all.
So one more question came, sir.
Yeah.
Question is the fatty pancreas related in any way to the idiopathic pediatric pancreatitis?
Sure. As I said, nowadays the patients, apart from in the idiopathic pediatric group, pancreatitis, if the patient is having obesity, that makes him 80% at risk for development of idiopathic acute pancreatitis. So obesity is the major culprit. Nowadays we should educate at the pediatric MASLD and pediatric fatty pancreas is becoming very significantly higher in given population. Right now the US is facing the major trouble. United States and UK are facing major trouble, and they have started screening surveillance at the school levels, at the junior colleges level, etc., to tackle this. So we will have a session in upcoming sessions if we have time regarding this fatty pancreas also, which is a very upcoming topic. And yes, there is definite association with this too. Acute idiopathic pancreatitis and fatty pancreas, there is a definite association.
I think if there is no question, we can end.
Yeah. Close.
Sir. You want to say something, sir?
No, nothing. It's a good topic, and your chat, you have viewed it very nicely.
Thank you,
moderated it nicely, and I think many people have been benefited, and
Yes,
it will
sir.
be going on. It's a continuing our education, At the age
Yes.
of 80, I can understand.
Good. Yes, sir.
I can learn more. I also learning more.
Definitely, sir.
Yeah.
Every day is a learning day.
Correct. So till our last breath, we should learn and go. Okay. Thank you very much, Ganesh. Thanks, Panir. Thanks.
Thank you, sir. Thank you so much.
Thank you, Dr. Ganesh, for an insightful
Thank
session,
you, sir.
sir.
Thank you, sir. We all feel proud and happy also to have you with you, sir. To have you with us.
Thank you.
Thank you, sir.
Thank you.
Thank you so much.
Bye.
Thank you,
Bye.
sir. Thank you all the participants also. Have a good evening.
Right.
Thank you, sir, for moderating. Thank you, sir. Thank you, everyone.
Thank you, sir.
Thank you, Ganesh. All the best.
Thank you, sir.